Tom, thank you so much for this beautiful introduction and for the concept of these easy descriptors. It's a bit confusing. We have easy descriptors. This means something you detect immediately. It's spot on. You don't need to think about it. You say, this is an endometrioma. This is a simple cyst. On the other hand, you have simple rules, and the name is simple rules, but you have to study a bit. And this afternoon, we will test this a bit, and that's why now I think it's a good idea to go over them once again. It doesn't harm to go over them many times and to study what are the simple rules, actually. Well, the simple rules is simply saying if you have features suggestive of a malignant tumor and no features for benign tumor, it's called a malignant, probably a malignant tumor. If you have features of a benign tumor and no features of malignant, it's benign. And if you have conflicting features, so if you have one feature for benign, one for malignant, you cannot conclude what it is. It's inconclusive. And sometimes you have no features, and then it's inconclusive as well. And in about 22% of cases, it's inconclusive. So what are the features for a malignant tumor? First, irregular solid tumor. And as Professor Valentin told you yesterday, solid tumor means at least 80% of solid tissue in a two-dimensional image. So you don't need to do a 3D to calculate the volume and see what's the proportion. No, you simply look into one image, and if less than 20% is cystic and the remainder is solid, it's purely solid. So this is not multilocular solid. It's a solid tumor because the bulk of it is solid. And as soon as you see something irregular, be it in this cyst internally, or be it on the outside that the tumor is not really smooth and regular, then it's irregular solid. So these two need to be combined. If it's smooth and solid, it's not a feature of malignancy, because then you only have about 30% risk of malignancy. If it's irregular and solid, the risk of malignancy is much higher. So that's why in these simple rules and the features, we combine features. Second is presence of ascites, and once again, yesterday it was told that ascites is the presence of any fluid outside of the pelvis. So it's not a little bit of fluid in the cul-de-sac, in the pouch of Douglas. No, it's if you see fluid outside of the pelvis. And in doubt, please look transabdominally as well, and maybe in the Morson's pouch to see whether there's fluid between the liver and the right kidney. And if you see fluid over there, then you can be pretty sure there's ascites. And presence of ascites is also a feature of malignancy. Then at least 4 papillations. So yesterday we said you have to count until 4, and then it's enough. So if you have 4 or more papillations, you say, so you don't need to count to 17 or 16. That's not needed. It's no papillations, 1 papillation, 2, 3, 4, and that's it. So if you have at least 4 papillations, it's a sign of malignancy. But if you have 2 papillations, that does not mean that it's a benign tumor. No, then you cannot use this feature. So this is very important. People think, well, if it's 3 papillations, then it's not malignant, so then it's benign. No, this is the beauty of the system. You have to combine the different features to get to the reliable system. Because one feature of its own is not reliable, but a combination of features, if you say we have 1 or 2 benign features and there's no malignant feature, and that's important, no malignant feature, then it's benign. So you always have to combine and see the whole thing as one system to classify the tumors. Then irregular multilocular solid tumor with largest diameter of at least 10 centimeters. So this is not one morphological feature, it's a combination of features. It should be N irregular, N multilocular solid, and the largest diameter should be at least 10 centimeters. So that's a combination of features, but if the 3 are present, like in these cases, then it's M4, it's the 4th feature of malignancy. And then finally, the last feature of a malignant tumor is the presence of very strong blood flow. And yesterday it's been discussed already, blood flow is a bit subjective. That's why we don't like it so much and we try to get rid of it. And in that next, you don't see blood flow anymore. And this is it's not by accident, it's by choice. Because blood flow is important, and I encourage you to use Doppler in all the tumors that you look at, because sometimes you think this is solid and it's cystic, and vice versa. And color Doppler will help you to distinguish between these two. But if you see a lot of flow, so if it's really abundant, if it's more than what you expect by looking at grayscale image, that's color score 4. Color score 1 is you don't see any flow. 2 is minimal. You really have to look hard to find some blood vessels. 3 is moderately strong, and 4 is very strong. And it's reassuring to see that there's little inter-observer variability between 1 and 4, but we know that some people are more generous and they give color score 3, and others give color score 2. But if you have color score 2 and 3, it's not in the simple rules. You cannot use it. That's not discriminative. That's not discrimination between benign and malignant. So let's look at the benign features. The first is a unilocular cyst. So it's only one local. And here you say, well, this is multilocular. Well, no, this is not multilocular. If you have a little bit of experience, and if you are in doubt, you call it not unilocular. But this case is hemorrhagic. So these are fibrin threads. And for this, again, it's useful to switch on your color Doppler to make sure that there's no blood vessels inside, because then you have to change your mind. You can gently touch upon the tumor with your probe to see whether you see this jelly-like movement. And in that case, you are absolutely certain that it's hemorrhagic content. Blood clots, fibrin threads, you see them moving if you touch upon the cyst. If it's a multilocular tumor, the septa, they go along with the cyst, but there's not this jelly-like movement. So this is helpful as well. But once again, we always say, in case of doubt, go for the worst case scenario. So if you have, for example, a multilocular cyst with one locus filled with ground glass fluid and others with anechoic, we call it ground glass. For example, if we are not sure whether something is solid or not, then you are playing it on the safe side by calling it solid. So in case of doubt, you go for the worst case scenario. The second feature of a benign tumor is the presence of solid components, where the largest solid component has a diameter of less than 7 millimeters. For example, if you have one population, and the height here would be 6 millimeters, and this is 9 millimeters, in that case, it's not applicable, because the largest diameter is not the height of the population here. The largest diameter is from here to here, that's 9 millimeters. That's over 7 millimeters, so this is not suggestive of a benign tumor. If this is 6 millimeters and this is 4 millimeters, then it's a feature of a benign tumor. Okay? If it's too difficult, you have to tell me, but the features as they are, I think, are pretty unequivocal, but sometimes you need to think a little bit about what is really meant with them. The presence of acoustic shadows, originally this was developed to look at dermoid cysts, of course, but in some cases we see them also after in the wall of cystadenofibromas. In these populations, you see subtle acoustic shadows. But sometimes you see them in malignancies as well. And once again, hopefully, these malignant tumors will have other features, color score 4 or others, to prevent misclassification. The fourth feature is smooth multilocular tumor with largest diameter less than 10 centimeters. And finally, blood flow is absent. So color score 1, no blood flow. And this does not mean that you don't see any flow on your image. It means that you don't see any flow in the lesion. So sometimes you have a lesion, a dermoid cyst, and surrounded by normal ovarian stroma. If you see flow in the normal ovarian stroma, that does not mean that there's no flow in the lesion. The rule is that there should not be flow in the lesion. And if this is the case, then it's B5. So to summarize, once again, last time that I will summarize it, rules for malignancy: presence of ascites, irregular solid tumor, at least 4 papillations, irregular multilocular solid tumor, at least 10 centimeters in diameter, and a very strong blood flow, color score 4. Rules for benign tumors: unilocular tumors or cyst. If the solid component is less than 7 millimeters in largest diameter, a smooth multilocular tumor less than 10 centimeters in largest diameters, and no detectable blood flow, and finally the presence of acoustic shadows. So these are features that are suggestive of a benign tumor. If we combine these and we tested them, and this was the publication in the BMJ based on IOTA 2, then it proved that these 10, this is not rules of course, this is wrong, these are 10 features were applicable in 77% of the tumors, or the rules were applicable. Sensitivity is 92%, specificity is 96%, so you can pretty well rule out malignancy. And of course, there's a few types of tumors where we struggle, and this is mainly in the borderlines, because 50% of borderline tumors are not classifiable with simple rules. And if we look in terms of correct classification, then we see that 96% of benign tumors are correctly classified, only 80% of borderlines, 94% of primary invasive tumors, and 95% of the metastatic tumors. And they're not all as strong as they look. For example, if you see acoustic shadows, 11% is malignant. If you see at least 4 papillations, only 77% is malignant. So none of these features is 100% predictive for benign or malignant, but yet again, it's the combination of them. If you apply the rules, then it becomes reliable. And it is reliable if you look at the old centers. Sensitivity for cancer was 93% overall, specificity 87%. In the new centers, so this is external validation, 92%, 89%. Premenopausal patients, 92, 91. Postmenopausal, 93, 83. So to some people, it might be confusing. And in November, we had this consensus meeting in the United States, and they said it's all too complex. Can we not come to something more practical, something more simple? And I tried to summarize the talks over there, and it fits perfectly in with what Tom proposed. And this is pattern recognition. It's the easy descriptors first, and if you see a cyst which is clearly benign, be it simple cyst, a dermoid, and a meteoma, then you're in this group. It's group 1. And if you think it's functional, there's no harm in repeating the ultrasound scan. So it's always a good idea, in case of doubt, is this a hemorrhagic cyst, yes or no? Simply ask the patient to come back after a few weeks, and then you will know. So there's really no shame and no harm in doing a repeat ultrasound scan. If she has no symptoms, and it's a benign tumor, it's not functional, you can do like we do in IOTA 5, and do repeat follow-up after 3 months, 6 months, and then yearly. If there are any symptoms, then you might discuss surgery. On the other hand, if it's clearly malignant, be it because there's ascites, high color score, and postmenopausal patient, or if you have a patient where you happen to see a C1 to 5 result, and it's over 100, and she is more than 50 years old, then it's always a safe option, we believe, to refer the patient to the gynae oncologist. And he might want to use the next model to see whether this is a metastatic tumor or borderline, and discuss fertility sparing surgery or discuss primary investigations, mammography, colonoscopy, to exclude a primary tumor. And then in the group which is not immediately classifiable, you can either go for the expert, you can apply the simple rules, so that's the second step in the three-step strategy, or you can apply the ADNEX model, or you can refer the patient for MRI, but this has still to be proven. And if the simple rules conclude that it's probably a benign tumor, you can do the follow-up. If they conclude it's a malignant tumor, you refer the patient to a gynecologist. And if they are inconclusive, what can we do then? Any idea? What do you say? Expert, yes. Or MRI, maybe. Or refer all of them to the gynecologist. So you can classify all of them as possibly malignant. So I think this is really very practical, and this is a real-life application of how you can integrate the different algorithms. But now I would like to ask Ben van Calster, because he did something with the simple rules to make them useful for all patients, just not the 88%, the 77%, but to 100% of patients. Thank you.
Ja, moet dit gebruiken? Niet meer het systeem. Oké. No, just yeah. So, as Dirk already mentioned, not all features in the simple rules are equally predictive of malignancy or of a benign tumor. And so I used that idea to quantify the risk using the simple rules. So simple rules are very attractive, and this is logical because the simple rules are simple. But to me, that comes with a downside. You don't have any risk estimate. It's just an algorithm that tells you this is benign, malignant, or inconclusive. And so that's why I tried to get risk estimates for simple rules. This is work in progress, so I will simply mention the general idea and not go into too much detail. So it's based on logistic regression analysis, but that's not really important at this point. So you have the 10 features here again. So on top you have the 5 B features, and at the bottom you have the 5 M features. And using statistical analysis, I could give a score to every feature. You can see, of course, here I am again. I added also type of center into my analysis, which is at the bottom. You can see, for example, that the B1 feature, unilocular cyst, gets the lowest score. So this is most predictive of a benign tumor, which is probably not a surprise. And then the B3 feature, presence of acoustic shadows, has the highest score for the or the worst score for the B features, -3. So that's the B feature that is least predictive, well, in relative terms, least predictive of a benign tumor. And then for the malignant tumors, you have something similar, and there all the scores are positive because they are predictive of malignancy. And the strongest feature is M2, presence of ascites. And then the weakest one is M4, irregular multilocular solid tumor with largest diameter of at least 10 centimeters. And examination at an oncology center, and I still got many questions about this yesterday, but you can see that if you add it to the analysis, it also gets a score of 2, which is the same as the score for the weakest M feature. And you have to bear in mind that all M features are very predictive of malignancy, so the weakest one is still quite predictive. So this means that, again, here, there is some predictive value in the type of center where patients are examined. Now, how do you apply this? Well, assume that you have a patient where 2 features apply, B1 and B5. No other features apply, and she's examined at not a non-oncology center, let's say, so I also took out the bottom part here. So then only two scores are left, and you sum them up, that's minus 11. And then this corresponds to a risk of 0.15%. And how you get from the sum score to the risk, that's something in the background, that's not too relevant here. For another, well, I have to give the general idea. For another example, you have a patient where B3 applies and M5 applies. So the original simple rules classification would say this is an inconclusive patient. And this patient is examined at an oncology center. And so then you have -3 + 3 + 2 is a sum score of 2. And that corresponds to a risk of 51%. Now, if nothing applies, so we have many patients where, in fact, none of the features apply. And also, if they are examined at another type of center than an oncology center, then your score is 0 + 0 + 0. And that corresponds to a risk of around 28%. So that's the general idea. Now, how you get from the sum score to the risk, there's basically a table. It's a fixed table. So you compute the sum score for your patient, and you link it to the risk estimate that you see in the table. So that's the general idea of using the simple rules to also get an estimated risk of malignancy. So actually, it can really be added to the simple rules as you use it right now. You can, or we could add it to the app with the simple rules quite easily, such that it is all done automatically.